Today, the topic of my talk was innovations in transfusion management of patients with sickle cell disease. As many hematologists and transfusion specialists know, patients with sickle cell disease are at increased risk for alloimmunization, meaning they make antibodies to some of the proteins on the transfused red blood cells. And mainly what we are focusing on is using genotyping and genetic tools to help improve matching of patients with their blood donors. So we recently have identified that many patients with sickle cell disease, because they're primarily of African ancestry, have significant genetic heterogeneity in the Rh gene, which encodes the second most immunogenic protein. So aside from matching blood for ABO, most of us know that we get matched for RhD, but there are other Rh proteins as well. And these are usually the blood proteins that patients with sickle cell disease make. So oftentimes when patients make these antibodies, we're not sure what kind of blood we should transfuse them with. So first off, we can use genotyping to identify whether the patients themselves have a variant in the Rh protein. Sometimes we see that they don't have variants, and so we hypothesize that the reason why they're making these antibodies is because the blood that we find that best matches the patient is often from donors of their same ethnic background. And likely in the case of sickle cell disease, many of these patients are exposed to donor blood with different Rh variants and make Rh antibodies because they saw a protein different from their own. So we hope that in the future we can use these genetic tools when we can come up with ways to do it much more cost effectively, I should say, in terms of just the genotyping itself is quite expensive. We hope that one day we can match the patients who are at most risk of developing these antibodies with donors who are genetically matched on their Rh locus. So hopefully for patients, that means that they'll have better transfusion outcomes. They won't make antibodies to the transfused red blood cells that they receive. And what that oftentimes leads to is delays in transfusion, and for some, they become untransfusable. So they won't be able to get blood when they really need it. So by focusing on a preventative strategy, we hope that patients won't be in that predicament where we can't find them blood that will be able to be safely transfused with. The primary challenge we have is that the Rh genes are actually a duplicated gene family, and so some of the next generation sequencing technology that's out there doesn't provide long enough reads for us to correctly map whether a segment of the gene that we sequence belongs to the RhD gene or the RhCE gene. So there's actually many groups around the world that are working on better technology to improve Rh genotyping at a cost point that will be palatable to hospital services and transfusion services in terms of how much it would cost to get a genotype matched unit of blood.